Hello, everyone. I'm Stuart Marcus. I'm the founder, chief executive officer, and chief medical officer of Sonalicent. And our company's name comes from sonosensitization with ALA. That's the molecule. That's a sonosensitizer. And our tagline is soundly defeating cancer, which I will get to. And really, this is about appreciation of the molecule ALA, which is part of the heme metabolic pathway. We're going to talk about photodynamic therapy and how it evolved into sonodynamic therapy. This is the heme pathway, also known as the dreaded heme pathway to medical students and residents. The heme pathway is important for the production of the molecule heme, which is necessary for hemoglobin and the synthesis of cytochromes in all oxygen-utilizing cells. All our cells, most, if not all of our cells, have this machinery, but it is carefully controlled. And it was found a while ago that if you add the first committed pathway molecule in the pathway, which is 5-aminolevulinic acid, or ALA, it will rapidly move through the pathway and accumulate as the molecule protoporphyrin 9, and it's pink because it fluoresces pink. This fluorescence from activation by light, so when you shine a light on cells accumulating protoporphyrin, they go up to a higher energy level. They can release that energy as fluorescence with people in neuro-oncology and neurosurgery used to detect as a visual aid for tumor resection. But what you can also do instead of the fluorescence is you can use a higher energy of light and create a photodynamic effect where the energy from protoporphyrin is transferred to molecular oxygen, which becomes a highly reactive singlet oxygen, and that leads to immediate cell death and apoptosis of the cell that this is occurring in. This is photodynamic therapy, or the photodynamic effect. I spent 27 years in a company, Dusa Pharmaceuticals, that developed a topical form of ALA. And what you see here illustrates that ALA is a precursor molecule. If you put it on the skin, this is porcine skin seen in contrast, phase contrast microscopy, fluorescence microscopy. In 1 hour, you don't see anything, but at 4 hours, you see very selective fluorescence only within the epidermis, stopping at the dermal-epidermal junction. You can let it go for 24 hours and you will still only see fluorescence in the epidermis. This is important because we developed a way to treat skin cancer and precancers using photodynamic therapy by activating this protoporphyrin with light. I can show you an example now of photodynamic therapy, which really is impressive in terms of the tumor selectivity. This is a patient with Gorlin syndrome. They're born with also known as basal cell nevus syndrome. They're born with a patch gene mutation that leads them to develop hundreds of basal cell carcinoma over the course of their lives. And as you can see here, in the patient who's had many basal cell carcinoma resections, he's got scars, he's got also hypopigmented areas from cryosurgery. And what you can see is that it's a difficult thing to do and to tolerate. This is using topical ALA photodynamic therapy in children with Gorlin syndrome. This child was treated, and then you're seeing this about 3 hours after photodynamic therapy. You can see the inflammation is located only in the basal cell carcinomas, primarily, and these are scars from prior surgeries. And you can see 2 months later that the patient is completely resolved and the cosmetic effects are amazing. There's no scarring. The only effect is on the epidermis. This is important in terms of you being neurosurgeons and neuro-oncologists, most likely. But what you see here is a young girl on this panel A. This is a young girl, 7 years old, who developed a medulloblastoma. And she was treated as standard procedure, standard protocol, standard of care with external beam radiation therapy tracking along the spine. What they didn't know, because it hadn't demonstrated her yet, was that she has the PATS gene mutation in Gorlin syndrome. And what she did was develop, because of the external beam radiation, she developed hundreds of basal cell carcinomas along the radiation track. This is on her front. There is also one on her back. And to remove this by surgery would have taken a lot of flaps and would have resulted in scars. We treated her. This was a compassionate case with Dr. Alan Osseroff at Roswell Park Cancer Center. We treated her with 7 PDT treatments, and this is the result. She's completely cleared. She remained clear for 5 years, which is not uncommon because of the immune effects of photodynamic therapy. So this is what ALA, photodynamic therapy, when you activate protoporphyrin with enough light to create a photodynamic effect, you have this wonderful effect. Now, when I see a glioblastoma in a patient who has taken oral ALA as Gleolan, and I see this is courtesy of Dr. Nader Sinai at the Ivy Brain Tumor Center in Phoenix, I see this wonderful glowing material, and I want to treat it immediately with light. I know you'd like to remove it, but wouldn't it be better if you could kill it with light? And indeed you can. There's one center in the world in Europe that developed PDT run by Walter Stummer, who was the originator also of Gleolan fluorescence. Walter Stummer is able to treat glioblastoma with photodynamic therapy, but it's not commercially viable. Despite positive results, there have only been 2 publications from his laboratory, and this is what it takes. You require a laser, you have to do a craniotomy, you have to do stereotactic placement of fiber optics, measure protoporphyrin before and after treatment. This is simply not a commercialization process. However, what if you could use the energy of sound to produce light within the brain, within the tumor, non-invasively, to produce a photodynamic effect? That is what photodynamic therapy is. And as a company, we are committed at Synalysins to developing photodynamic therapy to commercialization as soon as possible, with the first indication being recurrent glioblastoma. We're also going to be working with Dr. Roger Packer this summer to treat patients with diffuse intrinsic pontine glioma. And the potential is also there to treat metastatic brain tumors to the brain and low-grade gliomas. The device, which I don't have to explain to you, that we're using is the Exablade 4000 Type 2, the 220 kilohertz, the same one that's being used with microbubbles to open the blood-brain barrier for better drug delivery. However, photodynamic therapy does not use microbubbles, nor does it open up the blood-brain barrier. Photodynamic therapy simply uses the 220 kilohertz frequency and targeting, and it uses energies which are somewhat greater than those used for blood-brain barrier opening. This is simply a preclinical study that was done in Japan in 2018, and it simply shows of mice with gliomas. Only the combination of ultrasound and ALA extends survival significantly. The top Kaplan-Meier graph, I'll go into a little bit. It was a study that was done in Professor Kullervo Hennenen's lab in Sunnybrook in Toronto, and we used C6 rat glioma. And just to get into this a little bit, this is a C6 rat glioma model, and the survival is shown here of the control, the focused ultrasound alone, and the ALA alone. And you can see all those animals died at or before day 21. We used a single point of sonication in the tumor at 32 degrees and 37 degrees, because when you do photodynamic therapy on the skin, a higher temperature will give you a better effect. However, in this case, it was the lower temperature that doubled the survival of these animals, and the higher temperature also increases survival by 50%. We optimized photodynamic therapy in this rat glioma model by using a multi-point sonication. Instead of using sonication at a single point in the tumor, we did a grid of 16 points in 20 minutes, which is 75 seconds per point in the grid. And what that result was in this light blue line, you can see it extended out beyond 60 days and greatly extended survival. This is the model that we are using, multi-point sonication in human tumors. How does it work? My personal hypothesis, this is our current working hypothesis, is that the mechanism, and this is also Kullervo-Heinonen's hypothesis, so I think I'm in good company with that. The mechanism is likely to be sonoluminescence, and I'll show you why. This is sonoluminescence seen in water, driven at 1 megahertz. And this is what you see as the spectrum. It's rather bluish. If you look at the actual spectrum of the output spectrum of sonoluminescence in water, this is what you see. It peaks at around 300, has significant intensity out to almost 500 nanometers wavelength. Why is this important for photodynamic therapy with ALA? Because as we saw it with photodynamic therapy, the active agent is protoporphyrin. This yellow line here is the light absorption spectrum of protoporphyrin. This is the Serre band with highest absorption, and the action spectrum tends to follow the actual absorption spectrum. So what you see here is that in the Serre band, and then you have Q bands going out to about 635 nanometer. So what you see here is that sonoluminescence has a spectrum which activates the entire molecule of protoporphyrin, all potential sources of singlet oxygen and activation of protoporphyrin. And this blue bar you see here is the spectrum, output spectrum of the actual blue light that I and my team developed at DUSA Pharmaceuticals for topical ALA PDT, and which is now in thousands of dermatologist offices. So it is a very logical thing to see that you would expect a very good result with photodynamic therapy with ALA. And this is the currently running phase 0-2 clinical trial design. Phase 0, because the tumor is removed after treatment. Phase 2, because it's a classical dose ranging study. We're using our proprietary intravenous formulation of ALA, which obviates some of the side effects of the oral ALA. We already received orphan drug designation in the US. We've applied for that in the EU. The Ivy Brain Tumor Center is currently accruing patients to this study. It's a single center study. And it is a dose escalation study in which there's a fixed dose of ALA, 3 increasing dose energy cohorts. The objective is safety, determining potential dose-limiting toxicity of SDT. Is there a strong inflammatory response resulting in cerebral edema? Is there damage to non-targeted areas of the brain? And in all photodynamic studies that we've done for safety, we've been fortunate enough to see efficacy. So we are hoping that even at the lowest targeted energy, we will see some degree of efficacy. If we see efficacy, but safety is adequate, we, after 3 patients, will move on to the next cohort, which will be doubling of the first cohort energy. And if that cohort shows complete safety, we will move on to the 3rd cohort, which will be doubling the energy dose of the 2nd cohort. So we end up with a cohort 3 has 4 times the energy dose of cohort 1. Should this prove effective and we see tumor effects and complete safety, we plan to develop this commercially, go to the FDA and develop this with a phase 2B multi-center, multinational study to begin in the first quarter of 2022, which is lightning fast for any kind of drug development. But we're very committed to doing this. So we are Senalisense, and we are soundly defeating cancer. Thank you very much for your attention.